today's speaker, Andrea Martin. Today we're going to be talking about the exciting topic of vestibulodynia. So hopefully a lot of people will learn some new things and talk about kind of how to integrate both the kind of like medical side and the physical therapy side, because we have a lot of clients that we work together with, specifically with this diagnosis and many other pelvic pain diagnoses. And Andrea has just been such a pleasure to have as a referral source, and has helped a lot of women in South Jersey. So thank you very much. So Andrea is a board certified women's health nurse practitioner, which enables her to offer reproductive and sexual health care to all genders. She obtained her bachelor's degree in animal science from Rutgers University, as well as a bachelor's in nursing from William Patterson University. She received her master's degree in nursing science from Rutgers University and a doctorate degree in nursing science from Misericordia University. Her nursing experience includes inpatient medical, surgical, and telemetry care, and her nurse practitioner expertise has encompassed family planning, gynecology, urogynecology, and sexual medicine. She is an active member of the International Society for the Study of Women's Sexual Health and currently works at Virtua Sexual Wellness and Pelvic Health in Southern New Jersey. In her free time, she enjoys caring for her pets. I'm really excited about this part, as well as cross-stitching nerdy medical humor designs. Wow. We might have to see some of those designs.
I have a couple behind me.
Okay. Nice. That's awesome. Well, welcome, Andrea. Thank you so much for joining us today. We're excited to be able to talk with you about this topic.
Thank you. It's so lovely to be here. You both have been amazing, and I'm, sorry you had to go through the bios are the worst. They're so boring. Nobody really cares.
Okay. I love reading them.
I actually learned, so I didn't realize you had multiple degrees, like even your doctorate in nursing. So I'm just very impressed with all of the hard work you've done to get to where you are.
Chronic student, a bit of a dork. Can't stop.
Yes, I understand.
We are self-proclaimed dorks as well.
Yeah.
So this is going along.
Yeah, so I'm so excited to talk about this today. I see so many patients with vestibulodynia, and I'm glad that we're kind of on this platform collaborating between physical therapy and nurse practitioner, because patients get to their care provider different ways. Sometimes they start with me, sometimes they start with you. And I could not do what I do without pelvic floor physical therapists. Like, just forget it. I wouldn't get anywhere. And the one reason I feel like when I see patients that like kind of started with physical therapy and they're not progressing, it's usually because there's an issue with their skin that needs to be addressed. Mm-hmm. And, in order to have a happy pelvis, you've got to have happy skin, happy tissues, happy muscles. So without everybody getting addressed, that's sometimes where patients stall. And, the more it's fantastic. Like, I think you guys are good at like being like, you know what, I think there's something going on with your tissue here. Like, let's get that looked at. And once we work together, it's so helpful for getting patients kind of over that threshold and making more progress.
Mm-hmm. Yeah. You can't stretch vulvodynia away. You can't sometimes stretch pelvic floor, any other pelvic floor dysfunctions away by being pelvic therapist. It's part of it. And it's that multidisciplinary connection that we need with our other providers like you to make it well worth the effort on everybody's part. And I think that's when sometimes people do feel like, well, pelvic therapy didn't work for me. It's like, right, because it wasn't the only thing. Or like, oh, estrogen didn't work for me. And it's like, because it all goes together. And I think that that's finally a myth in like pelvic floor land that people are starting to see more of, that we truly need more and more of this integrated interdisciplinary connection.
Yep. And it's pretty rare for me that I see anyone with like just vestibulodynia or just pelvic floor dysfunction. Like, they almost always go hand in hand. So you absolutely need to treat both. And just kind of breaking down the word vestibulodynia, it sounds like this weird. It's just like, what does that even mean? Anytime you see a medical word that ends in dynia, that just means pain. So pain of the vestibule. And a lot of people are like, what the heck is the vestibule? one of my patients, I love it. She calls it the lobby to her vagina. And I'm like, that's a perfect explanation.
True.
And the vestibule is so unique, and I love it and hate it in so many ways. But it's literally, I have Mary here. This is Mary.
Oh, but she has a name.
She does. I name all of my pelvic models, but you can't see it. So basically, your vulva, it's the outside. Vagina is the tube on the inside. You can't see it from the outside. So the vestibule is, once you spread the labia, it's all this kind of circle of tissue right in here. And it's super unique because it's literally bladder tissue that's sitting on the outside of your body. So embryologically, the vagina, the vulva, and the vestibule are all different. They're all in close proximity, but they're all different. The vulva is ectoderm, the vestibule is endoderm, and then the vagina is mesoderm. Who cares? Basically, what it means is that you've got literal, like if you were a man, that tissue would just be like kind of inside your urethra. In a woman, it starts in the urethra and then it just kind of splays out onto the outside of the body. So a lot of times in vestibulodynia, we see patients that also have a lot of urinary symptoms. And they're like, I think it's interstitial cystitis. I think I'm having recurrent urinary tract infections. But it's just that annoying little circle of tissue right there that's causing the problem. So
interesting.
I don't think I understood that it was truly the same tissue embryologically from when we were babes, how everything grew and differentiated. I don't think I understood that it was the same bladder tissue, but it makes sense for when we have that like burny, stingy, but then it also comes with, oh my God, I gotta pee, I gotta pee, I gotta pee.
Yep.
That makes sense.
Yeah. And a lot of times, I'll ask patients, first of all, diagnosing vestibulodynia is literally the easiest thing in the world. Like my dog could do it. You take a Q-tip, a moistened Q-tip, and you just touch the vestibule like, does that hurt? Does that hurt? Right. It doesn't take a rocket scientist, but a lot of times I'll touch them, like, does that feel like the feeling? Or does that feel like you have to pee? Does that feel like your UTI? And they're like, yes, it's there. So, I always tell these patients, I'm like, you were right. Like, it is your bladder, like you're feeling bladder symptoms, but it's just that part of the body. Other symptoms patients have a lot is like kind of like this hypersensitivity. Like walking around, you shouldn't be aware of your vestibule, but a lot of patients are, like burning, rawness, itching, dryness, pain with sex, especially pain kind of like at the opening, not necessarily a deeper pain. Can't wear tight pants, bike riding's off limits. Even with walking, sometimes like the friction back and forth can be really uncomfortable for patients.
Mm-hmm. Yeah, so often, like those are our questions we ask and we want to know. So we can start to like think, okay, yeah, it's not just pelvic floor, or it's not maybe like vascular pressure that's there. It could be more of vestibulodynia or vulvodynia.
Yeah, I think oftentimes too, I mean, you kind of alluded to it, where vestibulodynia and pelvic floor dysfunction kind of go hand in hand a lot of times. So someone might be having a lot of other symptoms of pelvic floor dysfunction that as we're kind of working together, we're kind of like tossing through the weeds. And then because I've experienced this with a lot of clients where they have this overall just kind of like diffuse kind of pelvic pain where it's not localized to one area. So as we're working together, certain things are improving. And then it's like, okay, it's just this localized, like burning pain right at the entrance of my vagina. Like everything else has gotten, a lot better as far as some urinary symptoms or other pelvic pain or other things going on. So sometimes it's like that missing piece of the puzzle with some of that tissue there. And as pelvic therapists, I think, like I'm trying to get better at is observing the vulvar tissues and the vestibular tissues. And are there things that we can kind of notice as pelvic floor therapists that might indicate that like there's some tissue kind of component to it, as well as like a muscular component.
Yeah, to refer more quickly to get things going. Literally, like I know we do the Q-tip test, like that's part of our thing, but like I don't always know what to do with it. So that's when, we say, okay, there's like a positive Q-tip test at this little pinpoint, and it's like, okay, you're seeing Andrea. Like
Absolutely. And some of that's so hard, like God, I wish I could just show you on every patient because like it's simple. You get it in 2 seconds, but like that's, why I'm here, happy to do it. But a lot of times like you'll see more sensitivity in like the gland openings, like if you think of the vestibule like a clock, the bottom of the clock is usually more related to like the muscles underneath being like super tense and tight. But the crazy thing is it's like it is insanely easy to treat. And I will say too, you'll get a lot of clues from patient history. So like some of the most, if we look at, there's different types of vestibulodynia. So I would say probably the most common one is hormonally mediated vestibulodynia, which it just means you're not getting enough hormone to that tissue. So the vestibule is extremely hormone sensitive. It loves estrogen and it loves testosterone. So we see patients, if they're menopausal, perimenopausal, birth control is a huge one. Breastfeeding is a huge one. Patients on different types of cancer treatments, even patients with gender affirming therapy, a lot of trans males will get vestibulodynia. So, kind of looking at and putting it in context. And if you've got a little bit of dryness, sensitivity, whatever at that area, you can kind of put the puzzle pieces together.
Yeah, I think one thing from like originally, like when I first started pelvic therapy, it was like, okay, vestibulodynia is this thing that happens to the inflammatory response. It's usually perimenopausal, postmenopausal. But the more I was spending time with our clients, and our population tends to be a lot of gals in their 20s, 30s, and 40s in the childbearing years. And you would see this fluctuation of, I had these dry, irritating symptoms when I was on birth control, when I like didn't want to have a baby. And then people come off of it, they're like, oh, and then it like increased with sex, but then it kind of got better. And then I was pregnant and it went away. And then all of a sudden, like it comes back, and people like, it almost plays with your mind thinking, oh my gosh, do I have chronic UTIs? Do I have chronic yeast infections? What's going on? But I feel like so much more with our postpartum breastfeeding gals specifically, that there is this hormonal mediated vestibulodynia that no one's addressing, or we're blaming it was a perineal tear, you're fine. And it's like, no, like that perineal tear is a portion of it that maybe increased the tension of that area, but also that hormonal kind of component to it. So we have to look at it from all directions. So that was one of my biggest learning things in the past few years.
Yeah. And it drives me nuts because, of course, all these patients are just told, like, just use lube. And they're like, I am using lube. Like, I'm not an idiot. And I'm sure this helps in the frequency, but, like, it's not getting to the root of the problem.
Yeah, exactly.
And patients, they've got so much going on. You're trying to breastfeed and you just made a new human and recover all this stuff. And then nobody's helping them. It drives me nuts. But even like you said, a lot of your patients are younger. And I've got, 20-year-olds that have hormonally mediated vestibulodynia, and it's their birth control. And I'm not saying like everyone go out and, throw out your birth control. I love birth control. Like if you're on birth control and you're not having pain, dryness, like you're good. That's fine. Stick with it. We actually know now that patients who do have pain with birth control, they've done research on the receptor sites in the vestibule. And they're called these like basically patients who are more prone to this pain have what are called CAG repeats, but it's kind of like a defect in the receptors in the tissue. So the way birth control works is a lot of times, and it depends on the type of birth control. Your liver produces more of this protein called sex hormone binding globulin that basically acts as like Pac-Man. Any kind of estrogen, testosterone that's floating around, it's just kind of like not going to let it get to the receptor site. So in patients who, just are more susceptible to this, then they end up having more pain. So again, like this isn't anti-birth control by any means. And I will say for my patients that have vestibulodynia, I kind of go over which birth controls would be like least offensive to the vestibule. Mm-hmm. And it's always like a progestin IUD, copper IUD, the Nexplanon, or like a progestin only pill. Except for Slind, which is great. It's a newer birth control pill, but it has drospirenone in it, which is super harsh on the vestibule, very anti-androgenic. So there are birth controls that you can go on that won't make things worse.
Good to know.
Yeah, absolutely.
Yeah. I think that's with anything of like trying to kind of meet the clients where they're at too. I'm not just saying like, well, it's birth control, like, oh, you just can't be on birth control. Well, what if someone's like, well, I really, want to have an option. So it's and that's where
yeah, like you can either have no pain or you can have a baby you don't want.
Yeah,
There's no
right. It's
Have
not
your
like
choice.
one or the other. Yeah. Yeah. And
Absolutely.
that's where I think like we know of the relationship of birth control with it. So those are the questions that we're asking, but then it's not really within our scope to then
Right.
be recommending like, oh, you should switch your birth control or try this or try that. So that's where again, it's like very helpful to have this multidisciplinary approach. And sometimes I feel like a lot of chronic pelvic pain patients and clients have just been like tossed around and not listened to. So sometimes it can be really challenging to have that conversation with clients who are sitting in our office because they have lost a little bit of trust in the medical system. And here we are trying to refer them to a medical provider where, that's where, kind of the education piece to it, the conversation, but also I think sometimes people just have to be ready to receive that information as well. I've had lots of clients where, we talk about it the first session and they're like, nope, not really interested in it. I'm like, okay, I'm not going to bring it up for a few sessions. We're going to do what we're going to do. And then you start to slowly kind of have those conversations again. And I was talking to you, Dr. Mann. I was like, I think I'm going to have like a come to Jesus conversation with this one client of mine because we just are stuck. And I really, truly think this is like what it is. And it was so funny because she came in that day and she was like, so I was thinking about what you said last time and
dropped a little
yeah. So but
follow the breadcrumb trail.
Yeah, sometimes you put the information out there. She went and did a lot of homework about it and came in and she was ready. So
I know, and I get it. Like you can tell sometimes I'll just see in the first visit in a patient's face that they've just had it, and I'm like, you have zero reason to trust me. Like, why did you? You have seen so many people. They've treated you like crap, or they've promised you the world. It's done nothing for you. You spend all this money. Like, I get it. I don't expect you to be like, you're going to fix everything. Like, I'll tell you what I have to say and I will support you. And I promise I'm never going to be like, oh, it's all in your head. But like, it's a tough journey. And I completely understand when patients are like, oh, why should I trust you?
Yeah. I was just going to say, like, it must be super frustrating. Like, I'm like laughing, but not laughing because I think it's funny. I'm laughing because like, this is so ridiculous that you're like, it's so easy to treat. And it's like, well, why are these people just not getting sent to the right person if it is that easy to kind of work with and improve with, all of the treatment options that we actually have for this? Like, why is it so hard for people to get to the right person to help them?
I literally walked into a patient room the other day, like I was reading through her history, and I'm like, nope, they didn't give her vaginal estrogen. Did they? No. And I walked in the room, I was like, I'm so mad for you.
Yeah.
So simple. She's probably like, who is this crazy person? Like, so riled up. Like, this is stupid easy. Like, anyone can do this.
Right.
But
I think that's the thing. Like, a lot of our gynecology partners in all of this, like, yes, they understand things, but like, it's not their bread and butter. Like, babies and pap smears are like the bread and butter for most gynecologists. And I apologize for anybody who does not do that. I get it. But like, we need to know that there's more people like yourself. Like in South Jersey, honestly, there's your group that you're part of, maybe one other. Like,
I know there's not much.
Like crickets. Like, we need more people doing this.
I know. And I'm not like, and I don't try to crap on like the OBGYNs and all that, because like their schedules are insane. It is impossible. They have to address so much stuff. Like there's no time. But I always say, like, if you got to be able to either like refer patients somewhere or like educate yourself on it and, help them out a little bit, but not this just like, okay, well, we're done. Patients like, okay, well, we didn't address anything. But I definitely would like to get into like what we were talking about, the treatment options.
Yeah,
super easy. Like, it is basically for most people just a little bit of estrogen does the trick. Sometimes we use estrogen plus testosterone. Sometimes my most favorite is a product that has DHEA in it, and then DHEA splits off into estrogen and testosterone. So the reason testosterone kind of comes into play, one of the biggest reasons, when you look like under the microscope and stain the specimens at the glands, the lining of the glands in the vestibule, they are so rich in testosterone. So testosterone really helps kind of replenish those glands and help with lubrication. And it makes a big difference for patients that are really sensitive at those gland openings. And estrogen it brings in blood flow, it brings in lubrication, it makes the skin more elastic and stretchy instead of, dry and brittle. It prevents urinary tract infections as well. But it's super easy. You can do it. I think the most effective way for the vestibule is a cream. And I get it. A lot of people are just like, I don't want to put a cream. It's messy, but like, you gotta be able to coat the tissue. You can get like a regular commercial brand, like estradiol is the generic. There's Premarin cream, or sometimes we end up compounding. I try to use generic when I can, commercial when I can, because usually it's cheaper. But for some patients, their tissues are so sensitive. And this is why it's important. Some people will be like, I tried estrogen cream and it burned. Mm-hmm. A lot of like Premarin stuff like that has alcohol in it, which is so stupid. Like you're putting it on your vestibule and you've got alcohol in it. So sometimes we got to go the compounded route first, use like a really, really gentle base, and then get their skin integrity back up. And then sometimes I can switch them back over to the kind of the cheaper stuff. But anything with testosterone in it, we have to compound it. It doesn't exist in the regular world.
Oh, wow.
And then, and the DHEA I was talking about, that's a suppository called Intrarosa, which is fantastic. Of course, insurance doesn't cover it most of the times because it's my favorite, but it's super easy to treat. And depending on what's causing it, like if it's because you're breastfeeding, like it's just temporary. You don't have to use that medication forever. Mm-hmm. If it's for menopause, then like you should be using that until the day you die. Like your hormones are never coming back. And those changes that happen to the vagina and vestibule are progressive. They get worse and worse over time if you don't treat it. So really kind of as far as the length of time of treatment depends on kind of what the initial issue was.
Yeah, and kind of where you're at maybe in your lifespan of what's going on. That makes sense.
Yeah.
Everyone asks about the safety of like hormones. Could you talk about that?
We could do an entire pod. Whatever. I'm just that. I'm so passionate about this. Vaginal estrogen and vaginal hormones are one of the most safest thing ever. Like it's over the counter in Europe. When you get like I know.
Add another thing, brings another thing to Europe. We're packing up.
Over the counter in Europe has a black box warning in the United States. So when you get your package, say, of Premarin cream or estradiol cream, you'll get this giant package insert that says it's going to give you blood clots, dementia, breast cancer, you're going to have a heart attack, all this kind of stuff. And then I always think the patients are probably sitting there thinking like, I thought Andrea was so nice. Why is she trying to kill me? What is this? That black box warning is an absolute piece of crap. Use it for kindling. Use it for toilet paper. I don't care. It is garbage. There's so many layers to this, but basically there's a difference between whole body estrogen, so systemic estrogen, and just local vaginal estrogen. No one has ever gotten a blood clot or breast cancer, anything like that from vaginal estrogen. It does not happen. We have so many studies that show it's safe. As far as systemic estrogen, that is incredibly safe too. Topic for another time, not what we're here to talk about, but like that whole warning basically is unfair to all types of estrogen, but especially local estrogen. Mm-hmm. There was, I would say, the most recent study that kind of made people nervous a little bit. There was one that came out in 2022. It was like a Danish study. They were looking specifically at women who had breast cancer that were on aromatase inhibitors, like anastrozole is an example of one, and they saw like a slight increased risk in recurrence. However, when we like really look at this study, and it's literally just one study, we don't have anything else to support it. There is a lot of missing information here. They didn't say like what type of systemic or local estrogen patients were on, what the dose was. They said that patients who were using estrogen, they said as long as they refilled the prescription twice, so what, maybe like 2 months or 6 months, depending on the type of thing that they were like a user of vaginal estrogen. So we don't even really know how long they were using it. They didn't define what recurrence meant. Like if it was a local breast cancer, like could it have been residual disease? Like there's a lot of information missing. So I understand. I still feel very strongly that for patients on aromatase inhibitors that it's safe. But I understand if that, conversation makes you nervous, you want to talk more about your medical provider with it. That's fine. But there is no reason that any breast cancer survivor, anyone who's had a heart attack, blood clot, dementia, anything should ever be denied vaginal estrogen. Paint the world in vaginal estrogen.
What about our breastfeeding moms? Because there's always that question.
Mm-hmm.
Like, I don't want to take anything. Could it go through my breast milk? Is my child going to grow boobs? Like that kind of
or affect my milk
or
supply.
affect my milk supply,
Yeah.
right?
No, it's a great question. It's super safe in breastfeeding women. We prescribe it all the time. When you look at, and there's different formulations of how the estrogen is supplied, whether it's a cream, whether it's an insert. When they study women's like blood levels of estrogen with these different medications, the systemic absorption is so little. It's not even like you're basically still in menopausal states of estrogen. So like whatever estrogen you have is equivalent to that of like an 80-year-old woman. Like it's nothing you have to worry about with, how it will affect your baby, milk supply, that kind of stuff. And the other thing to look at too is there's different levels of absorption as to where you put the cream. So vulva, vestibule, not much absorption. First, kind of like near the entrance of the vagina, like the bottom of the vagina, a little bit more. Back of the vagina has the most absorption. So for most of these patients, the pain is right around the opening. So there's no need to be like stuffing a bunch of cream or whatever, like all the way at the back of the vagina. So it's really, really limiting, how much exposure they have.
That makes sense.
Mm-hmm. Yeah.
I was just thinking about kind of what you were saying with like how the tissue, comes from its bladder tissue.
Mm-hmm.
And I'm sitting here thinking, I'm like, I wonder if people maybe they're not having like the burning, itching, raw, painful, but they're having more of those like urgency, like UTI like symptoms that we could be.
Do you use it up there around the urethra? Is that where you're saying?
Well, that, and I'm just thinking like again how estrogen could be helpful for that population as well, and not just the like the burning raw pain with sex.
Absolutely. Yeah. There's a lot of patients that have like overactive bladder, things like that.
Mm-hmm.
And when you treat their vestibule, it makes a huge difference. So when you back Mary again, when you spread the labia, so like the urethral opening is right here. So when I have patients apply their cream, I always say like, think of it like a clock. Clitoris is 12 o'clock, and then we've got 6 o'clock down here. You take a dab of cream, start at 6 and swipe all the way up on one side, take a little bit more, swipe all the way up on the other side. And then if anything's missing, just kind of like color it in. So included in there is the urethral opening. And that really helps with those patients. And it's interesting because it helps, I get so many of those patients that are like, I have recurrent urinary tract infections. I'm like, okay, has anyone done cultures on you or whatever? And it's like, no, they treated on symptoms, or they did cultures, but they always come back negative. So great for them because they usually think they have infections. It feels just like an infection, but it isn't. But it's also really good for the people that have actual recurrent urinary tract infections because it just helps like the mucosal seal of the urethra. It helps that kind of stay closed. It helps with the whole microbiome of the vagina, all these things that just make it better at, fighting against urinary tract infections.
Right. It should be just as important as like if you put on night creams or day creams. Like I always say, like if you put your creams on your face, cream your area, put your other like beauty creams on for your vulva, and there's your nighttime routine.
I know. And patients are always like, ooh, I don't want, like, that seems gross. I'm like, are you grossed out when you put your cream on? And then, no, you're like, oh, this feels nice. I'm like, you don't need to have like it like glopping out, like it's just, like just kind of cover the tissue and move on with your life. That's all.
Exactly.
Oh, give her some love.
Yeah. So we talked a lot about the hormonal kind of mediated vestibulodynia, and then the other kind of type of vestibulodynia is the neuroproliferative. So if you want to talk about that a little bit.
So neuroproliferative just basically means that for most of these patients, they were just born with like too many nerve endings in that area. So the tissue from day one is just extra sensitive. And if you're going to stereotype patients, this typical patient that comes to me is like, I've never been able to use a tampon. I've never been able to have sex. I've never been able to have a pelvic exam. It's always been excruciating. So this was like it was never like, okay, at one point, and then it got bad. It's always been that way. And the part that makes me sad, a lot of the time, these patients, I see it pretty frequently in like more religious couples where they didn't have any sex before marriage, like no contact whatsoever. They're happy. They find their partner. They get married. They try to have sex and they just cannot do it. It is so incredibly painful. And then they're like, is this normal? Is this what it's supposed to be like? But because they maybe didn't have any kind of like stimulation to that area prior to then, they had absolutely no idea. So this one, it's really tough for people, but I'll also say like, it seems to be pretty easy to treat. Like I'm not having a hard time helping these patients out. Treatment is a little bit different. So there's kind of two ways you can go about treating this. For a long time, I feel like the idea was like the only option, the true option is surgery, like to completely remove your vestibule, which absolutely is a great option. I'm also seeing a lot of success with we use a compounded amitriptyline and ketamine cream. And it is working wonders for these patients, like amazing. I'll say this, I see a lot of patients sometimes on like a combination of like amitriptyline, gabapentin. There's another one I see sometimes, and I feel like it never works. Like I'm always, and then when they come to me and I'm like, I know I'm just throwing some other stupid compounded cream at you, but I swear this one works. I swear it. I never see the other ones work. I will say sometimes their tissue is so incredibly raw that to just go straight to the amitriptyline ketamine cream is just like putting fire on it. Like you can't do it. So a lot of times we have to kind of go in a stepwise approach, like start with a little bit of estrogen, add a little bit of estrogen, testosterone, switch to the amitriptyline ketamine, but go at like a lower percentage until we finally get up to where we need to be. But it absolutely can be treated. It absolutely can get better. And then where the vestibulectomy comes in, which is the surgery, basically like if you just like don't want to deal with those creams for, the rest of your life, some patients have to use the creams forever, some don't. That's a good option. I'll say I've seen a lot of patients recover from it that, do really well. One huge thing I would say is if you have a surgeon, you've got to have a surgeon that does this a lot. If they tell you that they just do a posterior vestibulectomy, don't do it. It's not, I don't understand the thought process from it. So basically, your vestibule, it all hurts. And they're like, we'll just remove this half. Well, you're still going to have pain up here. And then these patients end up, they go through all this and they're like, I'm still in pain. They're like, of course you are. They didn't remove the top half. So if you're going to do it all.
That totally makes sense. I know. And for us, like as pelvic therapists, we'll do the Q-tip test. We will see some positives with that. But it does seem to be that we can't even approach the vulva with our gloved lube, well lubed.
No.
no way, Jose. And there's a big emotional part of it too, of like, that area has never worked for me. We kind of, in some ways, disassociate from it. And that relationship with our vulva can be, quite neglected in some ways.
Yeah.
There's also, for our perspective, obviously, we're not doing the surgery. We're not able to prescribe the lovely creams and stuff that you can. But for us, we are trying to help people bridge that gap of like, you and your vulva are best friends. Like, this area is safe for you. And there's a lot of ways that we can do that, even without doing any internal work, if somebody is waiting for that time frame. And then afterwards, it's amazing to see the success, especially after a surgical intervention, of like, whoa, everyone's like, wait, you put your finger where? And it didn't hurt. Like, it's like this moment of epiphany for people. So it really
and how quickly
that
yeah. And even when we're working with clients with like dilators or that sort of thing, they're like, I'm already on like size 6.
And you're like, 2 weeks. Is your partner 6? I don't know.
No, it's fun. I agree. And approaching these patients, it's usually a super slow process. And I'm like, that's fine. Like, usually I talk, like, I'm like, we do this however you want. This is your visit. This is not my visit. So like, we can talk day one. You can come back another day. I'm like, sometimes I'll have patients, like, they kind of spread their vestibule and I just kind of see if I can peek. And I'm like, okay, we saw it. Maybe the next time I'll try and touch like one spot with the vestibule. And I'm like, normally I touch 6 spots. And I'm like, look, if I can barely touch with one spot and you're jumping off the table, like, it hurts. I don't need to be like, does this spot hurt? We're not doing that. And I have a lot of patients where it might be a while before I ever get to touch, but I can have them kind of guide it. Sometimes like, I'm like, let's just start with like, just try to like drop a glob of cream on there without even like touching it, rubbing it, whatever, and get some kind of little progress. And then the next visit, maybe they're actually able to spread their labia more. And, very stepwise approach. But I had a patient recently where it was literally like, she was terrified. Her legs were like clenched like this, like everything about her was clenched. And she was just like, it was not a thing. And literally her last visit, I came in, her legs are like open. She's like,
I love it. That's great progress.
This is so great. She's like, yeah. And I tried a new toy and it felt great and all this stuff. And I was like, I'm even gonna cry. I'm so happy. And like, it's such a huge difference from start to finish, but like, you can get there. You just gotta, take it really slow, and that's fine. Who cares?
Exactly.
So, yeah.
Tell us about the belly button connection, because that was something I learned from you after kind of co-treating with one of our other dear clients. So share with that.
Yeah, so it's very interesting with neuroproliferative vestibulodynia. A lot of times if you ask a patient, like, do you hate your belly button being touched? When you touch your belly button, you feel like this like lightning crotch sensation. A lot of times they're like, yes, what is that? So again, it all comes back to like embryology. That when we were, in the womb, there used to be this kind of like passageway, which how we eliminated urine from, through the placenta and all this stuff. And for some patients with neurovestibulodynia, for whatever reason, that it's like the urachus, it didn't really quite close up all the way. There's still some kind of connection there. So a lot of these patients, if they're not sure, I'll be like, can you touch your belly button? Or like, can I touch your belly button? And then sometimes they'll be like, that hurts. Like in my crotch. I feel it in my crotch. I'm like, yep, it's such a weird thing. I don't know who figured that out, but that is the connection. And I'll say, I don't see it in every single patient, but I do see it a fair amount.
Yeah. Especially when we go to like work on people's bellies first, before we even like look at their vulva or ask anybody to, widen their labes or anything. Like we'll work on their belly, and some people are like, that's so uncomfortable, or like that makes me have a heebie-jeebie feeling. And I'm like, my little like antennas start to go up.
Yeah. Absolutely. Yeah. It's so interesting and weird all in one.
Yeah. It is. Yeah. I've never been able to poke my husband's belly button.
Oh my God, do men have vulvodynia?
Oh, no. He checked his vestibule.
He has that connection. He hates his belly button being poked or touched. Yeah.
There's got to be an embryo physiological
He's
thing.
always got a lot of lint in his belly button.
Oh, I know. I don't know why they collect lint there. And then
well, he's Greek, so he's got a lot of
I know.
hair there. So anyways, neither here nor there. So one of the questions I had, Andrea, is so when you see someone, how are you kind of disseminating, like, is this more neuroproliferative? Is this hormone mediated? Like, how do you kind of decipher between the two? Or are there people that have a little bit of both? Or what's your process?
It's mostly based on history. And sometimes I'm wrong. Like there's been patients where I'm like, oh, this is definitely neuroproliferative. And then as we start working up the algorithm and I treat them with like hormones, they're like, I feel totally better. And I'm like, cool, that's not what I thought was going to happen, but I'm happy to. And there's also patients where I'm like, I cannot, like, this is hormonally mediated. They get better with the estrogen, but there's like nothing in your history that supports this. Like that happens sometimes, but 9 times out of 10, it's just based on their history and the timeline and kind of, you know, if they've been on birth control or breastfeeding or, you know, that type of thing where it all kind of comes together. And other times it's confusing because it's like, you know, I started birth control and I started using tampons at the same time and it was always painful. So it's like, I don't know. And then we just, all right, let's start with hormones, see if that works. If it doesn't, we, you know, progress our way up. So.
Yeah. My one question is related to our postpartum gals who have sustained maybe a high grade perineal tear, grade 3 or grade 4. Does that, depending on which direction does it go, does that just from an anatomical position, can that kind of tear into those glandular tissues that are at that posterior kind of?
I don't see why not. I mean,
Yeah.
You know, I can't think of a specific patient. And usually I don't see that, like, you know, they're not coming to me right after they have a baby. So a lot of times I don't see like it fresh, but I don't see why that could not happen.
Yeah. Because I just wonder when we have some of those gals who are making such great progress, but it remains this one pinpoint little spot. It's just very pinpoint. So sometimes it just makes you wonder, was that injured and the changes to the hormones of that tissue just in that one little area? Because it usually is kind of more, if we're thinking of our clock, like 5 and 4 or 7 and 8. So.
Yeah, absolutely. And I'll say this too. I think sometimes patients are a little bit nervous, understandably, of like, you know, right after birth, like, I can't put a cream in there yet. Like that doesn't seem safe. But like I used to work urogynecology. We did, you know, lots of surgery for pelvic organ prolapse. Like we routinely were like day 1, like start getting that estrogen cream in there after surgery. So we put it all up in there. So like it is very safe to use like right away after, you know, after birth, after surgery, things like that.
That's awesome.
Yeah.
Yeah. Well, that was very informative.
Absolutely.
I had fun. You guys are the best. And yeah, I say this all the time, but I'm like, man, would I suck at my job if I didn't have pelvic floor physical therapists?
It's true. We all need each other.
Yeah.
We can't be successful without you either.
Yeah.
We're like, I could do this part, but then I really need help for this part.
So if people are interested in kind of reaching out to you or even just learning more about all the fun little tidbits that you are always sharing on Instagram about like sexual health and wellness, what are some ways people can kind of find you?
I'm always busy on Instagram. I love the gram. My handle is Andrea Sexplains It All. So like Andrea.sexplains.it.all. Not the easiest one to explain. I forewarn, I have a problem with cursing. I'm very proud of myself. I didn't curse once on this.
You did great.
And I'm very responsive on Instagram. I love talking to people. And then I actually see patients at Virtua in Voorhees, New Jersey. So Virtua Sexual Health and I can't even remember the name.
Sexual wellness and pelvic health.
I think so.
Thank you. I think so. I mess it up all the time. But I'm perfect.
Yeah, we'll include that information in the little description too.
Yeah.
So, and I watch your reels and I laugh out loud all the time. So great content.
Well, thank you so much. Thank you so much.
All right.
So welcome.
Thank you.